welcome Dr. Ellensbach.
Hi, everybody. Good morning. Thank you for the invitation, and I'm super excited to tell you what's been going on in the immunology realm. I don't have any disclosures related to this talk, and I'm hoping to get through the learning objectives, which really I was targeting a broad audience. I wanted to, we've had just an explosion in genetic sequencing and descriptions of immune deficiencies. And so I think it's really helpful to categorize or have a framework to categorize the primary immune deficiency and primary immune regulatory disorders. And then we ended up working for the last 5 years on trying to stand up a structure, so put all the tools in place to discover new primary immune deficiencies. And I'll show you through a case-based approach kind of how we're doing that. But then also kind of tie it back into why it might matter in kind of the general pediatrics clinic and the other clinics as well. So I did residency here, and I was really excited to come out to this hospital, partly because there's a long history of collaboration and caring amongst faculty here. Everybody's very nice to each other, and this was exemplified by this. I was doing a chart review, and this was a note back from Hans to Ed Marcuse. And you can see we used to be a little bit more casual in our notes to each other. And so Hans said that his haphazard cycling habits have scared me sufficiently to ask Oliver, who is his son, to wear his bike helmet. So it ends up that Ed Marcuse was worried enough about his brain, and we appreciate that. The other side is, for those that don't know, we have a long history of immunology here at Seattle Children's. As you're walking from the GME office to the cafeteria, there's all the pictures of the chairs of pediatrics. And one of the first is Ralph Wedgwood. He came out in '62 from Cleveland, but before that was at Boston with Charlie Janeway Sr., who is kind of one of the grandfathers of immunology. He brought with him this rich understanding of immunology and questions around immunology. He ended up training Jane Shaler, who formed the Division of Pediatric Rheumatology, and Hans Ochs, who through the divisions of infectious diseases, and now we have our own division, the Division of Immunology. So Jane Shaler and Ralph Wedgwood, together with Starkey Davis, described the first report of Job syndrome, which is hyper IgE syndrome. C4 complement deficiency was initially described by Hans and Ralph. And then Hans went on to describe genetic basis, or the molecular basis, of Wiskott-Aldrich syndrome, hyper IgM syndrome, IPEX syndrome. So there's been a lot of really great discoveries here, and I was super excited to learn from these people. So inborn errors of immunity, Ralph Wedgwood actually was tapped by the WHO to be on the first committee to describe what it was to be an immune deficiency. And that was back in the 70s, and that turned into the IUIS, which is the International Union of Immunologic Societies. That now every other year or every 3 years puts out a report where you do a gene associated with a phenotype. So these are all human conditions. And the last report in 2022 had 485 genes. Our ImmuneSeq in-house genetic panel has over 700 genes. And so it's really, it takes a village in order to be experts at all of these conditions. And so doing this collaboratively, doing this as a collective group, interpretation group, I think is important, rather than sending it just to a company. And so we also have had a change in how we interpret diseases. So it used to be this pie chart where it was very siloed. You had either a risk of infections, or maybe you got EBV-related cancer, or you got autoimmunity, but it wasn't this kind of overlap. We now realize that this is definitely overlapping Venn diagrams. You might be in the rheumatology clinic or the hematology clinic, and you might have an immune deficiency. So what are these big umbrellas that we can kind of, no one's going to have all 700 genes on the tips of their fingers, but if you kind of break them down, generally 2/3 of the IUIS gene list are going to be primary immune deficiency diseases that you remember from medical school. These are going to be your inborn errors of immunity that really result in predominantly infections. They might have immune dysregulation in terms of autoimmunity or autoinflammation, but classic examples like severe combined immune deficiency, thankfully we have newborn screening for that now, but they're going to have severe, unusual, or refractory infections. XLA is X-linked agammaglobulinemia, where you don't make any antibodies or you don't have enough antibodies. You have sinopulmonary infections. There are other rarer forms of agammaglobulinemia, but that's kind of a category where predominantly you have infections. And then CGD is another more of one of the common immune deficiencies. Chronic granulomatous disease has really a high risk of fungal infections or severe bacterial infections. So that's kind of the more classic. And then you have primary immune regulatory disorders. And this was really a category pioneered, or the term was pioneered by Troy Torgerson. When he was here, he was studying all the different flavors that looked like IPEX. So IPEX is a disorder where you don't have regulatory T cells. So your cells that kind of tell the body that no, this is yourself. And there's a lot of different ways to get there, but this gene list has now expanded, and about 1/3 of the disorders are primary immune regulatory disorders. The point I'm trying to make with this is that they might not have any infections. They might still have an immune-related disorder or a monogenic disease, but they might not have any history of infection. And family history doesn't always predict, because some of these disorders are dominant. So how do we find these? And that was what I was really interested in. In training, kind of cross-training, I found many patients in the rheumatology clinic that had primary immune deficiencies, and I was really interested in how do we focus on this. So I took a page from one, Jean-Laurent Casanova and Laurent Abel. These are a team of geneticists that really focused on how to find monogenic diseases that cause severe infection related morbidity. And what they ended up doing, this wasn't a groundbreaking framework. We all know that if you have pneumocystis, pneumonia, or if you have PJP, you're probably going to need an immune workup. But what I'm showing you here is on the x-axis you have virulence. So if the pathogen is very, very weak or an opportunistic infection, most people do just fine. On the y-axis is the vulnerability or the human phenotype. And if you have an extremely strong human phenotype, so if you're very vulnerable to these opportunistic infections, you are right here. So how do we broaden that? Well, they ended up going not just with PJP, but they marched through the pathways that lead to chronic mucocutaneous candidiasis, which is a chronic problem with Candida that goes from kids all the way into adults. Almost universally, this means you have an IL-17 defect, so interleukin-17 can also be a problem in psoriasis. And it turns out if you're taking medicine that blocks IL-17 for psoriasis, at high doses, you get CMC. And so it's turning out that a lot of the patients, the adult patients that are getting these biologics, look just like our monogenic diseases. And then herpes encephalitis was another one. They were marching down the pathway that leads to type 1, type 3 interferon. And each family was kind of instructing us in terms of what the pathway was. And they were able to really define why most people that get herpes simplex virus don't get herpes encephalitis, whereas some of them do. The last category was BCG-osis, which is BCG vaccine is used in lots of other countries. And so I think because they had Institut Pasteur, they were really focusing in on this. But if you don't have severe combined immune deficiency and get disseminated BCG, you pretty much have an IL-12 interferon gamma defect. So they were really using this phenotype as flagging patients that needed that extra bit of work. And so that was really, really illustrative for me. And I wanted to set that up here. And so the tools that you end up needing is you need sequencing, which now, thankfully, we have a lot more access to. But that's only the first part. I'm not sure how many of you have sent genetic testing and gotten variants of uncertain significance. that's basically where it stops with most patients. And the really hard work, I think, is how do we validate these findings? How do we know what's actionable? And we're working in lots of different ways in terms of trying to understand that. So one is you can do creative ways to do variant analysis. You might miss it from a sequencing perspective. The second stage is you might miss the phenotype. So it might not just be the clinical features that you see in the clinic, it might also be the blood tests that we do. So we've been working really hard at trying to do more and more immunophenotyping. So drawing blood, finding out what flavors of T cells, what flavors of B cells. And a lot of these are from our laboratory CLIA approved, clinical tests. You can do antibody testing, you can do vaccine responses, you can do cytokine levels, so you can really nail down what the phenotype is. And then you do functional validation. Thankfully, the primary immune deficiency community is quite collaborative, we're quite friendly, and so you reach out across the aisle and try to find other families to really nail down what the defect is. And then hopefully you can close this loop and do precision medicine, which is the goal. So how do I bring that back to the general clinic? And I think these two cases really highlight why this is important. I'm going to present two cases of life-threatening viral disease and argue with you that it might not be as rare as you think. So the first case was a patient that came to our PICU. They were air flighted down, a 13-month-old Alaska Native male child. He was the youngest of 6 siblings and 2 parents that were all healthy. And the only past medical history is he had recurrent otitis media, about 4 courses of antibiotics, so nothing hugely abnormal, but also, substantial. Had up to date on his vaccines, was a month late, so that's not also unheard of. And I'm showing you a timeline here where time 0 is when they arrived at Seattle. 11 days prior, they went to a rural Alaska clinic with bilateral conjunctivitis, had erythromycin ointment given, and got caught up on his vaccines. 2 days later, had ear pain, got amoxicillin, started to have fever and cough, got broadened to Augmentin, and then the next day was quite sick, ended up being hospitalized with respiratory distress and stridor. Cervical lymphadenopathy was noticed and was somnolent, so had a lumbar puncture, had blood cultures, had viral studies done, and none of that was super revealing. They got ceftriaxone and racemic epi and dex, and the patient continued to worsen. They were transferred to Anchorage, and upon arrival, the patient started to have both inspiratory and expiratory stridor, and they were concerned actually for either a retropharyngeal abscess or an abscess somewhere in the neck. So the idea was to intubate them in the operating room. They were already broadened to meropenem and vancomycin. In the operating room, the anesthesiologist was able to communicate to us later that they had erythematous exudative pharynx with positive ulcers, ended up having edematous epiglottis with scattered white pustules. So this was quite concerning. This picture was not from the patient. This was just snagged from the internet, but the patient ended up being RSV and adeno-positive. It was not clear what was going on, and a drain was placed. The surgeons took out a lymph node and sent that for culture, but this patient was not improving. They came down. They needed quickly to go on ECMO, so extracorporeal membrane oxygenation, got VV ECMO, needed renal replacement therapy, was deemed to have sepsis with multi-organ failure, so was given plasmapheresis, broadened to meropenem linezolid, had the PAN consultation from all of the subspecialties. Rheumatology was concerned about macrophage activation syndrome, started anakinra. As the labs started to come back concerning for HLH or MAS, you can see the CXCL9 and soluble IL-2 are quite elevated, but the ferritin and fibrinogen were more modest. The white blood cell count was through the roof, and that had a very strong left shift, so infection was still very much on the differential, and the cytopenias were not terribly pronounced. They underwent a bone marrow biopsy to get more information, and sure enough, there were hemophagocytes present. a BAL was performed to try to figure out what was going on in the lungs, and that was negative by PCR for bacteria, fungus, and no growth on the lymph node. So next, the viral studies started to come back. We already knew the patient was RSV positive and adeno-positive, and now we know that the patient had lots of problems with viruses. So HSV1 was positive in the blood, in the CSF, and the BAL at very, very high copy numbers. CMV, EBV, HHV6 were all positive. The patient was HIV negative by RNA. They got cidofovir, acyclovir, IVIG, and the child ended up going on to be positive for measles, mumps, rubella virus. And they were negative for this varicella virus, which was very, very interesting. This was confirmed to be by the CDC to be vaccine strains. We ended up doing an immunology workup, and this is where our hands are tied behind our backs a little bit. The patient was on ECMO in extremis, had plasmapheresis. We couldn't send a lot of our testing. But the HLH testing here, normal NK cell function and normal perforin granzyme and XIAP was negative, so genetic testing was sent. Unfortunately, the patient continued to worsen. They were compassionately extubated, and they died with the family at bedside. So not even a month later, the genetic testing was not yet back. A second family came down. This was for a completely different reason. This was a 15-month-old Alaska Native female with neurodevelopmental regression. And this was starting to occur at 8 to 9 months of age. No past medical history prior to that. She had loss of milestones, and I'm not a neurologist, so forgive me if this is a little cursory, but myoclonic jerks, hypotonia, head lag, these are all very concerning, of course. Thankfully, our colleagues in neurology was able to do outreach, and they were concerned about a progressive myoclonic epilepsy, and a negative genetic panel was sent. The MRI showed volume loss, and the EEG was abnormal, but no seizures. I'm showing you again a timeline. So time 0 is when they came to Children's. 5 weeks earlier, they were admitted for influenza A infection, pneumonia, was treated appropriately, improved, got catch-up vaccines because their 12-month vaccines were delayed. 3 days later, came back into the hospital, this time with influenza B and concern for aspiration pneumonia. They were treated, transferred to Anchorage. Their respiratory status waxed and waned. It ended up needing PICU and then went to the floor, went back to the PICU. They ended up having a rash that was waxing and waning as well. It changed in form over time. And this new papular rash showed some crusting that's why the patient was on clindamycin. But the respiratory status was fine when they were being transferred down. It was really a transfer to our hospital for coordination of subspecialty care, needing a neurology team, needing G-tube placement, needing the respiratory status checked. Whole exome and mitochondrial sequencing were sent because they needed to figure out why this was neurologic regression was happening. And when they came down, they actually left on room air and came on in respiratory distress, needing the PICU, had BiPAP, multifocal pneumonia, spent 3 weeks in the ICU. There was concern that this rash was actually vesicular, and they unroofed that. And they found VZV on the skin, blood, BAL, the CSF. They thought maybe the regression was due to a viral disease. I think everybody had been kind of aware given the last case, and everybody was checking for vaccine strains. So they ended up sending this to the CDC. VZV was positive. The MMR was negative. So very interesting that they were able to clear one but not the other. This time we were not as hindered in terms of our immunology workup. Immunoglobulins, if anything, were elevated. Protective viral studies or vaccine studies to tetanus and Haemophilus. They had all their flavors of lymphocyte subsets, and they functioned normally in a dish. So from all of our functional studies, they didn't have any problems with degranulation of their tissue, which might lead you to think that they had HLH. And we were still waiting the exome sequencing results. So This is where I think some of the challenge with interpreting genetic sequencing comes is we ended up getting the in-house panel back on case number 1 first, and it showed a homozygous variant of uncertain significance in IFNAR2. And IFNAR2 is one of the subunits of the type 1 interferon receptor. And why this is important, I'll get to in a couple slides, but I got really piqued by this genetic hit because it was homozygous, number 1. So you need one from mom, one from dad. And it wasn't anywhere in all the databases in terms of the populations. And it's not because we don't have many. Each of these has hundreds of thousands of people. And then the second case came back, the exome showed the exact same variant. So now we have 2 unrelated families, both with this homozygous variant in IFNAR2, and it's a missense mutation. We don't know if it's effective or not, or defective or not. So this is where I reached out. I formed a team because there's lots of questions. And first, we had to reach out to the families, make sure they wanted us to pursue this. Second, we had to reach out to the YKHC, so the regional or local IRB has a IRB plus a tribal board. The Alaska Native Tribal Health Consortium is more of a larger group. And the South Central Foundation helps manage a lot of the healthcare. And so I was connected. So Maite de la Morena saw the first case, and I was the physician on the second case. Caitlin McGrath helped me interface with the CDC. So this was clearly a vaccine injury. And so we had to investigate that with VAERS and CISA. And then Alaska, I was connected through Jan England to Roz Singleton. Roz quickly pointed me to Matt Hirschfeld and Joe Klika, and they've been instrumental in kind of navigating how to kind of move this forward and do some testing when genetic testing is not very favorably looked at. And so Brenna Simons-Petrusa was also very helpful when we got to the point of testing. So my question to the IRB initially in the local regions was very simple, is like, how can we functionally test this? And then if yes, then kind of subsequent questions, is this a founder mutation? How common is this? And are any carriers affected? So the reason I pushed hard on this made exact sense, that this was an IFNAR2 deficiency. And the reason for that is humans have 3 types of interferons. Interferon is actually a term coined in 1957 by Isaacs and Lindemann when they took heat-killed virus, put it on cells, took the supernatant, treated other cells, and then tried to infect them with viruses. And those second cells did great. So they called that an interfering soluble substance. And it was later termed, we now have 13 different type 1 interferons. We have type 2 interferon and type 3. The type 1 interferon receptor is the one receptor for all 13 type 1 interferons, and it's ubiquitously expressed in the body. The signaling is very conserved in terms of these JAK proteins, so JAK1, TYK2, and these heterodimers come down, and the whole point of them is to upregulate hundreds of other genes that make your cell inhospitable for a virus. But you don't want those always being expressed, so you need this alarm signal. And type 1 interferons have the exact same signaling pathway as type 3 interferons. Now, type 3 interferon receptors are going to be on your mucosal surfaces. So on your mucosal surfaces, there's a little bit of redundancy. Is that why, a vaccine ends up bypassing that? We're not sure. But it got me very intrigued at this pathway. And the reason is because Chris Duncan and Sophie Hamilton, who I subsequently collaborated with, described the first case of IFNAR2 deficiency in 2015. And then the subsequent receptor, so IFNAR2 is right here, IFNAR1 is its partner. That had the same phenotype of MMR-related meningoencephalitis due to the vaccine, and it was described in populations in Europe. So it really fit with our phenotype. Now, type 2 interferon is a little bit different. It ends up being a solitary molecule, so interferon gamma is the only cytokine. It binds to a different receptor that's more restricted in its expression. And the signaling is STAT1 homodimers, and I'll get to why that's important in just a second. So this down here shows you logically, if you have IFNAR deficiency, so either IFNAR 1 or 2, you're going to have a milder immune deficiency because of this redundancy. If you have STAT2 IRF9, now you're knocking this out and this out. And STAT2 homozygous deficient patients do get MMR-related meningoencephalitis. So this is another one of those phenotypes where if you get meningoencephalitis shortly after getting the MMR vaccine, you need a very detailed immune workup. And then STAT1 knocks out all of your interferons, and that's a very severe phenotype that has lots of other features. So when you have a variant of uncertain significance and you're interested in working it out, you try to use every tool at your disposal. So crystal structures, so protein crystal structures, what I'm showing you. This ribbon is the cytokine, so that's type 1 interferon, interferon alpha, and this is the binding site between IFNAR2 and the cytokine. But this 53 position is nowhere near this binding site. And then when they mutated this, this ended up not changing the structure at all. Sophie Hamilton and Chris Duncan had a lot of the tools I needed to validate this. So they're in Newcastle in the UK. I reached out to them. They were happy to collaborate. And they only had this one mutation that would clearly knock out the protein because it's a frame shift, but this was a missense mutation. So how do we test this? They ended up having a deficient cell line. So if you grow a cell in a dish that doesn't have IFNAR2 and you just transduce it with an empty vector, so this is using a lentivirus to put things back into cells, and you don't put anything back in, you still have an IFNAR2 deficient cell. So this should not signal through type 1, but if you replace it with the wild type, now you should recover the phenotype. So type 1 interferons, as I was saying, they phosphorylate JAK1, so that's activating JAK1, and then they activate STAT1, STAT2, and that's right here. So sorry, the IFNAR2 wild type looks like this, where it signals in these proteins and shows phosphorylation, and this is a Western blot on the cells, whereas the knockout doesn't show this at all. And just to show that these proteins and these pathways are intact, you can do type 2 interferon and show that they're signaling just fine. So how about our protein? So this mutation that was found in the Alaska Native children looks just like the knockout. So it doesn't signal at all. It doesn't recapitulate the signaling pathway. So now we were quite hooked in terms of thinking that this was a knockout. And one other thing you can test is the pathway signals. I told you it signals hundreds of proteins or genes to then make proteins to fight viruses. You can look for these, and these are called interferon-inducible proteins. And so the vector alone is a knockout, so it shouldn't signal this way. You replace the wild type, it makes these proteins, but the serine 53 proline doesn't do it. So then we started to sound the alarm or kind of reach out to colleagues and say, are there other cases? And it turns out that in Greenland and in northern Canada, in the Nunavik community, there were other families that had this sort of phenotype. And what I'd like to point out here is this family in Greenland had carriers that were healthy. So being a carrier did not seem to impart the phenotype. You had to be homozygous for this mutation. And this patient was not vaccine confirmed, but it was very close in proximity time-wise to the MMR vaccine. And patient 2 similarly had MMR vaccine-related injury, did recover from that. So both of these patients recovered, not without some brain damage, but had that and then had fatal COVID afterwards. So it's not just vaccine-related viruses that these patients succumb to. Their sibling that was also homozygous had interferon or influenza-related ARDS, and then you heard the stories of our 2 patients. So then, thankfully, the patient from Greenland was very interested. Their family was in research, so they were able to contribute primary cells as well as the parents. So we had heterozygous parent controls. So C1, C2 are just healthy control individuals, likely a technician in a laboratory or something. And phosphorylated STAT1 shows that the pathway is active. P1 is the proband, so homozygous, as we would expect. They don't have any signaling. We did note that the protein was actually migrating lower on the Western blot, meaning it's likely altered in terms of glycosylation or something. And we showed that to be the case later on. The parent was a heterozygous and showing expression of both of these, but they don't make these interferon-inducible proteins. So I'll sum up a whole bunch of different experiments in one slide, but basically you then can go and challenge in a dish with various different viruses just to show what is the susceptibility. Is it to all viruses or just certain viruses? And so you can take these cell lines that were created in a dish, you can put primary patient cells in a dish and challenge them with all of these different viruses. And they had broadly impaired viral problems that were reinstated, I should say. So the complementary assay is to rescue the phenotype with the lentivirus in the patient cells, and that was the case. So it didn't matter if you were a double-stranded DNA virus, so herpes simplex, varicella, measles, mumps, or encephalomyocarditis virus. And we went on to show we didn't have access to genetic information from Alaska, but we did have access through IRB-approved, population studies in the Greenlandic population for 4,630 phased exomes that allowed us to figure out what the allele frequency was in this population. And I just wanted to spend a minute on this slide because I think allele frequency is a little bit ambiguous as a statistic. But 2.5 allele frequency, if you had 1,600 individuals, and that's demonstrated here, you have two alleles, which means one from mom, one from dad. That's chunks of DNA when I say alleles. So you have a healthy allele and a diseased allele. And 1,521 have two good copies. 78 are carriers, which is a lot, actually. And then one patient out of 1,600, so about the birth rate that happens in Alaska, is affected. So the question is, how do we do this? And so the answer, we really worked hard to build a partnership, working with Matt Hirschfeld, Joe Klika, going through the steps. We went back to all the IRBs, asked, can we publish this? So they said yes, so we published. Discuss with local pediatricians, get the word out, especially the infectious diseases doctors in Alaska. And we found two other cases that were sitting on genetic reports with the mutation. They just looked it up and they said, oh yeah, the patient's, has a diagnosis now. So some of it is the interpretation and not the access to sequencing. And then now we're stuck, or not stuck, we're just completing some of the Alaska population allele frequencies. So we needed to find a source. And this, I won't bore you with all the roadblocks, and hurdles that we had. But we did find an appropriate approved source. And part of it was we needed a test that only looked at one nucleotide. We needed a test that already had existing data. And I think most people are aware with pregnancy about what cell-free DNA is, but you can get DNA from serum as well. So we isolated DNA from serum from hundreds of patients in this region and used a digital droplet PCR. So that's a yes-no sort of PCR test to say, is the fragment having the disease allele or not? And this looks like this. So you have the diseased allele here. So this associates in a homozygous state with the disease. And this in the green is the healthy allele. And this is a Greenlandic parent of the patient. So it's a heterozygous carrier. So it looks like this. And when we tested it, 384 samples, only 3 didn't have DNA. So this is actually a good way to get DNA. And then you need a really sensitive test, which is why we did it this way. And 381 actually were tested. 14 patients or individuals were carriers. So this was 1 out of 27. So roughly the same. I think 80% of the samples in this region that we were sampling were Alaska Native descent. And so it's not clear if this would be a little bit higher. And Greenland had already screened, I said 2.4%. The populations in Nunavik have not screened yet, so we're not sure. But importantly, in the other region where we sometimes see patients in this hospital, which is America Samoa and Cook Islands, in the same sort of issue of this journal that we published in, I didn't realize at the time, but Jean-Laurent Casanova was also doing the exact same study in the Polynesian islands, and the sister sort of receptor, so IFNAR1, actually had a common mutation. And so that is something that should be thought about when you're seeing sick patients from these areas in the hospital. So in summary, I hope I've told you that this is a not so rare Arctic variant, that it's a null allele present at high frequency, but carriers are completely asymptomatic as far as we know. None of the parents have reported any issues or problems with infections, but homozygous individuals are at risk for life-threatening disease. Since then, several case reports have come out with other frame shifts or completely null alleles, but this was the first missense mutation. Whether there are other pathogenic missense that are rare or private is not clear, but prospective screening, I think, is necessary to avoid vaccine strain injury and create rapid treatment plans. So why is this important to study rare disorders? Well, I think it's taught us through COVID that this same exact phenotype actually can happen with autoantibodies. So Jean-Laurent Casanova, again, I keep saying that name, but he ended up studying severe COVID. So if you take a population of asymptomatic mild COVID patients, 663, compared to almost 1,000 severe ICU level life-threatening COVID, 10% of them had autoantibodies against type 1 interferon. So interferon alpha, interferon omega, that completely mimicked our monogenic disease. And he knew about this because of the monogenic studies of the kids. And so we know that that's the case, and that's because it knocks out this receptor. So just in the last few slides, I'm really interested in finding other cohorts. So one reason to come and give grand rounds is to kind of shake the trees and see what rare patients you guys have. But, some of it is what is enough to hang your hat on, in terms of what is enough to call phenotype. And I think we have some. So, X-linked agammaglobulinemia is the classic form of no B cells, but there are other forms of no B cells. So we had a patient that had a lymph node that looked like this. So we worked that up. And then I've been toying around with other cohorts, like Evans syndrome in children is 2 cell lines being down with autoantibodies. That's not super common. So we've been toying around with sequencing those patients. We're not yet at a point where we have a successful cohort, but that's some of the things we've been thinking about. So I'm trying to fill out sort of, this is what my lab kind of is doing, and trying to fill in the variant validation sort of process. And these are some of the genes that we're also interested in, and pulling in hits from genome-wide association studies that seem to be very impactful. And I really appreciate everybody's time. A special thanks to the families that trust us with their care and teaching us, to all the Alaska tribal boards and IRBs for dealing with all of my presentations, and to my collaborators in the UK at McGill and in Denmark. Thanks to David Rollins, especially for funding kind of some of the allele frequency and supporting that, and for being my mentor along the way, and the Center for Immunity and Immunotherapies for doing that. Hans, Maite, Troy for always listening and being mentors, my other divisions, and then Matt and Joe, who've kind of been side by side. So thanks.
Wow. Thank you so much. This is incredible work. If you're in the room, 2 things. 1, make sure and fill out an evaluation. If you can use the QR code. And if not, you'll be getting an email later today. If you have a question, please raise your hand and I will bring you a microphone. And if you're online, you can type your question and I will read it out in a second.
Thanks. That was a really great talk. My name's Tom Brogan, for those of you who don't know me, and I work in the ICU. And we have the benefit of being able to reach out to Eric and Maite and the rheumatology people, which I tell the residents that if they don't know what's going on, can they measure it like a sodium? And if it's high, make it lower. And if it's low, if they don't know, if they can't measure it, usually it's a decision tree like metabolic acidosis or respiratory. If there's more than two choices in the decision tree, get a consult. And if it's more than two consults, it's rheumatology or immunology. But my question is not for me, it's for the other people in the audience. Can they, like people in clinics, can they call you up and say, hey, I have this weird thing going on. Can you help me?
And I don't know if this is, the green light's not on.
Joe.
Okay. Yeah, yes, of course. We get calls all the time, but we should get them probably more. Once we started talking to pediatricians and infectious diseases docs in Alaska, that started to happen. And I think some of it will be a lot of the patients that already had problems in the last, several years. So 2-3 years probably are at their, in their memory, and they got diagnosed, I think. The question that the CDC asked was, we've been vaccinating since, the 80s. Why haven't we seen this? And I think some of the caution would be, I don't think we send viral study sequencing, from all the patients we should, or do that next step. If they died from meningitis, I think sending that is important.
Congratulations, Eric. That was a great talk. Just fascinating work. And it also, I think, shows the power of collaboration. It is amazing how you have navigated through the hoops, especially the Alaska Natives. So my understanding is that you want to identify these patients, the homozygous, and then these patients will have difficulty handling the vaccines because they will be infected. So it makes sense that you have the newborn screen because you'll be able to capture that, right? Similar to the SCID. But the SCID's newborn screen is a different mechanism. It's not genetic testing. Was that right? Or how do you implement this?
Yeah, we've thought about this a lot in terms of, so the newborn screen for each state is sent to different places. The SCID newborn screen is a molecular test. They look for new T cells coming out of the thymus, make these little excision circles that you can PCR amplify. And it tells you, do you have recent thymic function or not? And so it's really a screen for lymphopenia. So, and then the subsequent testing, it just flags people. So we have a good capture rate with that, and that's what you need. So a molecular test is not, unheard of in terms of that sort of approach. That makes a lot of sense. The problem is when we reached out, they send their newborn screen to Iowa, and Iowa is currently like 12 diseases back in terms of trying to get things validated and off the ground. So some of it is logistics. And support. You have to show it's cost effective to get on newborn screens. So some of it is doing the studies, and part of that was doing the allele frequency to show that there's an actual problem.
Thanks. We have a question online, and then I'll get to the rest of you in the room. For patients with these mutations, other than avoiding live vaccines and frequent hand washing, what management treatment options have been successful for them?
Yeah, that's the $1 million question, is what do we do once we find these patients? So I've been trying to be in communication with the group in New Zealand, also with the IFNAR1 mutations, and they've been putting patients on immunoglobulin replacement. It's not clear that that actually helps with a lot of these viral infections. I've worked with the infectious diseases docs in Alaska to change their practice in terms of where they send viral studies. So if you send it to ARUP or one of the commercial companies, you might get it back in 7 to 10 days. That's too long. And so sending it to a place where you get rapid turnaround can give you the power to pick the right antiviral, and then to have the antivirals on hand to maybe draw the test, send it, but empirically start something right away. rather than wait for them to ship, the antiviral. So having stuff on hand, also not sitting on it, I think is one of the big things is if you know a patient has this, you're not going to say, oh, you have a common cold, you're going to quickly do a broad screen. So I think all of those are going to help. But it's not clear that they'll be able to have a long life expectancy if we don't do something more definitive.
Eric, really, really exciting talk and impactful work. So thank you for all that you're doing. I just wanted to ask about how you're messaging the work and this new, there's renewed vaccine hesitancy right now, even in presidential campaigns. And I'm just wondering how you and your collaborators are navigating that, getting the word out that this is a real concern for certain patients without starting a firestorm.
Yeah, no, thanks for the question. That's we weren't sure how to proceed in terms of how to get the word out. So far, we've just contacted pediatricians and contacted infectious diseases docs. This, in terms of this allele frequency that I've done, it was all de-identified, not going back to patients. So even knowing that they're a carrier, that was not what was, the community didn't want that in terms of those that sat on the IRB or tribal board. And without first prospective consenting of each individual, that wasn't kind of requested. So I think it's the comment from the community was we're having such hard time with uptake of COVID vaccine right now. This is not what we need. We don't need this sort of information. But they also recognized they all had children that they didn't know if they were screened or not. They wanted their child screened. So I think the combination of just how severe this phenotype is, combined with having children in their families, made the decision a little bit more nuanced. And so I think that's the right question to be asking all along the way is how do we preserve kind of we don't want to discourage the general population in Alaska from getting vaccinated. That's going to protect way more people, and we'll do more harm if they don't get vaccinated just to protect a couple individuals. But we also want to screen them. So far, providers have taken newly born children and considered screening them individually. So prospectively going, kind of just sending single gene testing. We don't have the answer though. I would love input from, anyone that has advice.
Thank you, Eric, for this brilliant work and really exciting just to hear it. And the collaboration, as mentioned, was just really impressive to see and so cool to have worldwide science and the results that you're getting are really just impressive. Couple of questions. One is what are the implications for genetic counseling for families? It sounds like, I don't know if I'm using the right word, but penetrance, the likelihood that the alleles, the homozygotes would actually, you mentioned that this was the 6th child in a family that had 5 other children. So not as frequent maybe for having a homozygote offspring. And then also, what about I would think that the wild type viruses would be far worse for these children than the vaccine. So that to me, it seems like, the herd immunity is still so important for the community to protect the kids that would presumably have a very bad reaction to a wild type virus.
Yeah, no, thanks for those questions. That's, I totally agree with your second point that I don't want people to walk away thinking that this is just a problem with vaccines or weak viruses, because I think they equally died of kind of the viruses that most of the children were dealing just fine with. The first question was, I do think it could be just luck in that family of 6 that they didn't have 2 sort of children with homozygosity. The other family from Montreal or from northern Canada, from Nunavik, had 5 children and had 2 affected. So I think it's just a recessive gene that doesn't have any impact on carriers. And from you ended up, what was the second part? Yeah, so genetic counseling, no, thank you for that. Because we tried with, our families were very, very hesitant in terms of at least the two families that had the severely affected children did not want their other siblings checked. And their rationale was, they've made it this far, they're fine. You know, we don't want to do this genetic testing. And they didn't want to know. Almost certainly some of those children are carriers. So some of it goes back to Essie's question, is how do we navigate vaccine hesitancy? And it's a global problem for all vaccines, and what pediatricians are kind of really dealing with as more and more people say no to vaccines. But just showing, I think finding these patients is my first step. And then not causing the vaccine hesitancy is the other. Yeah.
Thanks. A couple more questions online.
Okay.
This one is similar. Thank you for a great presentation. Does this information influence how you recommend vaccines in populations that have a higher rate of mutation?
Yeah, that's a good question. In some of the patients where we're not sure what the immune deficiency is and we're concerned about ability to handle viral infections, sometimes we'll give the varicella vaccine first because we have an antiviral drug, and watch them very closely for skin lesions. So that's one approach. But usually I think if you're that concerned, you should have an immunologist, look at the patient and see with testing whether there is, whether there are low T cells or whether there's a problem that we could identify.
Would this immunodeficiency be theoretically amenable to gene therapy?
Oh yeah,
Julie Goose,
good
thank you.
question. So we have been thinking about this quite a bit because as carriers are healthy, this would be very amenable. And I went so far as to ask during one of our last IRB with the tribal board, just kind of this idea about definitive therapy and whether families are more receptive to things like gene therapy or newer things that have come FDA approved, or whether bone marrow transplant, is how that is viewed. And at least the few people that were at the board said, either one is fine. If you know how to fix the child, that's fine. So I think that moving forward, it's going to be individual dependent. It's going to be having the problem right now with these rare diseases and finding gene therapy is actually funding it and affording to do it. So I think given that this has a prevalence in a population might be more amenable to that, but it's not clear.
And then one more question. Are there any GI symptoms subacute in nature?
I mean, it would just be if there's GI symptoms for each virus. So, if you had CMV ulcers, things like that.
This was amazing. Thank you so much for all your hard work. This
Thanks for
does
having
not
us.
seem easy. So we really, really appreciate you being here. And thanks everybody for coming, and we'll see you all next week.